All right, everybody, we will go ahead and get started. Sorry, it's a little loud. Welcome to Medical Grand Rounds. Thank you for all of you who are here in person. We are obviously still broadcasting on Zoom as well. A little bit of a teaser for those who would like to attend in the next couple of weeks. On February 7th, we're going to welcome our own Dr. Sachin Wani, who is the Rady Endowed Chair in the Division of Gastroenterology, to speak about Barrett's esophagus and esophageal cancer. And then on February 14th, we'll welcome Dr. Jennifer Flythe, who is the chair of nephrology at the University of North Carolina, who will be delivering the 2024 Wallstrom Lecture this year. As a reminder, there is CME and MOC credit for all grand rounds. That'll be placed in the chat for folks today. And now I really am very pleased to welcome today's speaker, Dr. Hatem Sabawy. Dr. Sabawy is a professor of medicine in the Division of Medical Oncology here at CU. He's the Associate Director for Translational Research at the University of Colorado Cancer Center. He is the Stapp Endowed Chair for Cancer Research and the Director of Personalized Medicine at the University of Colorado Cancer Center. He did his undergraduate and his medical school training at Cairo University, where he also got a master's in science in clinical and chemical pathology. He then was a medical student at both Cairo University, as well as completing the MD-PhD training program at New York Medical College in Valhalla. He was an intern and a resident at the Qasr Al-Aini Teaching Hospital in Cairo, Egypt. He did fellowship training in his postdoctoral work at Rockefeller University, as well as at the NIH and the NCI. Dr. Sabawy is a translational physician scientist with expertise in stem cell biology, gene therapy, cell therapy, as well as the development of patient-derived organoids. His team's research focuses on the implementation of precision medicine. Dr. Sabawy is in pursuit of a future where personalized medicine transforms healthcare, particularly through regenerative medicine and in the oncology spaces. He really is optimistic that this type of personalized medicine, in which treatments are designed around an individual's genetic profile, will be the future of what we do, if not in oncology, but also beyond. His role as the director of the Translational Research Center is to facilitate the translation of laboratory findings, including the creation of agents, technologies, as well as treatment strategies, into investigator-initiated trials, and to make sure that those impact our patients. It really is a pleasure to welcome Dr. Sabawy to Medical Grand Rounds.
Good afternoon, everyone. I am honored and really, it's a great pleasure to be here first time at this auditorium. First time actually with all of you. I joined Andrews campus a bit more than a year ago, still finding my way around between the buildings. But after this wonderful introduction, I think I'm done. I don't need to go through. The introduction, I appreciate it very much, Jeff, and really a pleasure to meet all of you today. What I'm going to try to do is to give you an overview of what we are trying to do at the Cancer Center in terms of approaches for implementing precision medicine. Before I start, these are my disclosures. And today I will not be discussing any confidential information from any of these companies. I will not be recommending any off-target treatment. And for CME, please scan the code on the screen. The learning objectives are displayed. So what I'll try to do is to talk to you about the potential impact of molecular profiling on cancer patient care, and review some of the cases and some of the use of patient-derived organoids into clinical studies that I started during my tenure at Rutgers University before joining here, being part of the precision medicine program at Rutgers, and also with other national networks, and continuing on at Andrews. So I'm going to show you some of our data. Some are published, some are in final preparation. And my goal is that I hope to inspire you to really think more about the ultimate patient care and how we are actually doing our medical care. I'm honored to be part of the University of Colorado Cancer Center. This is the only NCI comprehensive cancer center in the state of Colorado, and one of just a little bit more than 50 cancer centers throughout the country. The key features of an NCI Comprehensive Cancer Center is the focus on translational research, clinical trials, innovative therapies, and improving patient care. So what I'll show you today are basically two main topics. First is a general introduction about these PDOs. What does it mean, a patient-derived organoid, for those who are not familiar with it? And secondly, showing some case studies from 3 different groups of patients on how we can use these to improve patient care and implement precision therapies. This is a statistics slide. We always like to start with it. So 2024 ACS cancer stats came out last week, and unfortunately showing that this year, 2024, there will be more than 2 million new cancer diagnoses in the US, and more than 611 patients will die from cancer. This is not because we're not doing a good job. We're actually doing a fantastic job in our research. So the graph displays the impact of cancer research and clinical trials on patient care and cancer care, and the number of cases that are averted from death due to cancer. However, most of our research and trials are focused on drugs. They're focused around the therapy itself. So the process simply in our current medicine is that there are preclinical studies done in these research labs. They identify a biomarker or a pathway or a target. It's usually called a driver oncogene if it is actually driving cancer development in these models. So we developed therapies against these. These can be targeted therapy, a drug that modulates the expression, antibody drug conjugate, many different platforms of therapy, all centered around the target. We try it in patients with the 4 general phases of clinical trials. The first important thing is showing safety of these compounds. And once they show an effect, then they proceed to approval and trials. I believe the future of medicine should not be centered on the target, but rather on the patient. If we center our drug design and therapy, and this applies both to cancer therapeutics and other therapeutics, on the different patients and how they each respond to the type of therapy that we are implementing, we might actually have a large impact on patient care. And this does not mean, by the way, designing trials for each patient. Personalized therapy trials are not N of 1 trials. They are N of many, but each one have a tailored therapy that is being tested in these types of trials. And this is the concept that's sometimes difficult to understand, how you personalize therapy. You need to develop ways to do these types of personalized therapies that are feasible. They meet the current need and also financially feasible for our institute. So thinking about this is actually a way to move forward by advancing care with technology. And this is what you're going to see today, how we can use advances in technology to be able to design these types of personalized therapy. So the current care for cancer patients now is generally using what is called precision medicine, deriving or defining the oncogenes. So patient develop diagnosis for any type of cancer. We take the tissue, we do what's called exome sequencing or other types of sequencing of these biopsy tissue. And this is limited because, for example, the current molecular studies done at CU Andrews is defined as exome sequencing in about 450 targets. We don't consider all the other genomic elements that correspond to the development of these tumors in each of these patients. Secondly, this is very static. We all know the DNA is not everything in each of these cells. The expression and the RNA and cell states are very important in determining responses to therapy. So if we increase the resolution of our data analysis and diagnosis by looking at single cells rather than the bulk of the tumor, and this can be done now here at CU Anschutz. And if we actually develop ways to identify or take these biopsies and develop them into models that we can test therapies on, we will be able to understand or provide better, more precise diagnostics and therapeutics. Ultimately, we want to be able to look at the full repertoire in these patient biopsies, meaning the exome sequencing or the whole genome sequencing for DNA analysis. Also, the expression profile using RNA transcriptomics, looking at metabolic pathways, how these cells would respond to therapy. The key here is not just applying the new technology. The key is actually multiplexing. We all know that we get very small amount of tissue, and to provide the ultimate care, we need to look at particular biomarkers required for advancing these types of therapies. So what I'll show you is a way that we developed to take these biopsies and provide more precise diagnostics and validation on a patient-by-patient therapy for therapeutic responses. And this is with the use of the organoid models, the patient-derived organoids. And you can think about them as a research model, but in these particular cases, I'll show you these studies are incorporated into the clinical studies, into the clinical care as part of either correlative data for clinical trials or data for actually implementing next line of therapy. How do these organoids look like? So these movies actually show on the top, the single cell derived organoid, how it grow. Usually they are stem cell derived. They start from a single cell and form a fully formed organoid in about 6 days to 10 to 15 days, depending on the tissue type and how they are actually dividing. The middle movie is a life or an actual time lapse of a 6-day single cell derived organoid. They are 3D, so they're hard to project. So we like to do these movies to actually show how they are. And the bottom is showing a system that we have at the MedOnc division here, where we could do all of this automated. These are all with robotic arms that move the plates into the imaging system and back into the culture incubator. We can do thousands and thousands of these in the same day, test different therapeutics, and then implement these for future therapies. So we have the system set up to be able to do these types of studies here. What can be done with these organoids, and are they different than any other biopsy-derived tissue? Actually, the 3D culture and the organoid system is not new. It's been around for decades. It just had different names, different nomenclature. So if you think about it, if you take the biopsy and you develop a sliced culture from it and you keep it in the culture for quite some time, it is a form of organoid. So this diagram is from a review a couple of years ago we put out, where it defines the nomenclature of these organoids based on their constitution, how they are grown, how they are derived. Simply, the organoid is different than the traditional cell line culture is that it has many different cell types. So it maintains the heterogeneity of the original tissue in these biopsies. Therefore, many studies have now proven that these are better models to use for cancer research, but also they are the ultimate model because they are derived from each patient in our case. So we have, throughout the last 6 years, we developed conditions to grow these in a clinical scale or in a clinical grade, meaning these are serum-free cultures done in conditions that can be CLIA certified and approved for development as an assay for companion diagnostic tests for treating patients. These are the first steps. There are other sources of organoids in the literature, and these are the iPS-derived cells. So you can actually, if biopsies are limited, you can take a skin biopsy from a patient, develop an iPS line, and then develop organoids from these. It's a long way around, a bit costly, but this is something that can be done here at the Gates Center at Andrews. We've also developed conditions for many different tumor types, recently published conditions for deriving lung cancer derived organoids. So we have the system set up for deriving these PDOs from different patient samples. Obviously, the question would be, okay, all of this interesting, so what can you do with it? So I'm going to show you cases from 3 different groups of patients and how we use them to develop assays focused on these organoids for improving therapeutics. And I like this to be more interactive. I'm not sure if there's any of the audience here, anyone from the ER, but this is a common case. It's a 59-year-old male presented to the ER with severe headache, nausea, and vomiting. The ER staff could not communicate with the patient very well, maybe because of the pain and headache, or for some other reason, but the partner of the patient reported severe dysarthria that's been progressive for the last few weeks. And there was no history of head trauma, hypertension, cardiovascular exams were normal. What does the audience think of the differential diagnosis of this patient? Anyone? You have an idea? Which one? You're right. Oops. So this is a case of glioblastoma. One of the most common, having trouble with this now. One of the most common presentation of a brain tumor is actually in the ER. Many of these patients go suddenly with these types of symptoms described on the slide, and they then undergo a CT and MRI. And with the MRI, T1 will first show a swelling, a tumor in the brain. The T1 contrast will define these regions, and then a FLAIR follow-up will show that this is an invasive tumor, meaning it's growing around the edges into the brain. That's how brain tumors or glioblastomas are diagnosed. The immediate care, and this is the current NCCN guideline, is maximum surgical resection, followed by treatment. There is a multidisciplinary care at Andrews here where the medical oncologist, the neurosurgeon, the team will define the treatment. However, the treatment is very limited. The treatment has not changed for the last 3 decades. And the treatment is combination of radiotherapy after surgical resection and temozolomide, a chemotherapeutic. This treatment causes failure of response, or treatment fails very frequently, usually within 13 months. So these patients unfortunately die. We asked the question, since these biopsies or surgical specimens are accessible, can we actually do something with them? So we developed a protocol where we can access these biopsies from the OR during surgical excision. This is done with a biobanking group. Some of this work is done in collaboration with Kevin Lally, the chair of neurosurgery here at Andrews. and other work was done previously in my previous institute. This is the platform. So we take a surgical specimen, we take this brain tumor biopsy, we develop a 3D culture PDO type of organoid, and from that, try to identify, is it possible to add a new line of therapy to the current standard of care, that is radiation and temozolomide. We did this on 12 patients. The list here is showing the criteria of these patients. When we take the biopsy, first thing is to confirm GBM diagnosis. The hallmark of GBM is the expression of GFAP. This is the biomarker. So all of these patients were positive for GFAP confirming GBM diagnosis. Then we developed these 3D organoid cultures in the lab. We want to validate the expression profile. So now we're going from a genomic identification of certain mutations in these, I'll show you, to a protein or IHC expression or IF fluorescence of these biomarkers to confirm the expression. This is done at the single cell level, and we defined the key biomarkers for these organoids in these studies that were published a couple of years ago. So showing you some of the multiomic data first, we've done whole genome sequencing, exome sequencing on these biopsies and on the PDO derived from them to show mimicry or that they maintain the same profile. We defined markers or key driver mutations. For example, here is shown P10 splice variant mutation. This is evidence for activation of PI3K signaling. We coupled this with a transcriptomic profile shown in the heat map. So the heat map is done to link the DNA data, the genomic data, to the cell states, to the expression with the RNA. And as you might notice, I'm not having difficulty using the pointer, but I'll just describe it. This includes the microenvironmental markers. So this is a key difference, is that we're not only looking at the tumor cells, but also the tumor microenvironment. And based on these studies, we designed these rationale combination therapies. In this case, we want to ask the question, can we develop new therapies that advance GBM patient care? Can we combine these with the standard of care to design a phase 1 study for this? And indeed, our assays show that the combination therapy in the last bar is much more effective than each of these single therapies. The plots in red are called Bliss synergy plots, and there you want to see values as high as 10 or higher. This is evidence for a high combination index or high synergy between these drugs. So we could develop sophisticated pharmacological assays in these PDOs to be able to design combination therapy. This is done in real time because I mentioned to you the live cell imaging system that we culture in. We can actually see all of these. So we have a real-time system where we can monitor apoptosis and cell death using activated caspases. So this gives us a clear idea of the dynamics of the responses to therapy. And this is shown some quantitation of these dynamics, again, confirming the synergy of the combination of these compounds. Next question we wanted to ask, can we actually use experimental therapies in this system? Can we design studies that we test experimental therapeutics in the same combination? So my lab is developing a new type of epigenetic therapy targeting polycomb signaling or PRC1. The target here is called BMI1. And we have a compound nearing the stage of getting into the late preclinical or phase 1 first in human studies. We tested this compound in the system here. And the idea is to test it with combination of the standard of care, radiation or the chemotherapy temozolomide. We use the biomarker for DNA damage repair. As you know, irradiation causes DNA damage repair. And the quantitation of these is shown here. So this is another assay that allow the use of these combination experimental therapy with standard of care in these PDOs, primary patient-derived models. Some would like to confirm these types of assays in vivo, so we can also in the lab take these PDOs and transplant them or implant them into NOD/SCID gamma deficient mice as an orthotopic brain-derived model and show the similar effects of the inhibitors in vivo with a system here called IVIS imaging, which allows to monitor the cells that express luciferase. These are the signals that you're seeing in the mouse model in the bottom. And with the treatment, you want to see this tumor signal to decrease. So this is more of a preclinical approach to show that these GBM patient-derived models can be used to study experimental therapies and develop combination with standard of care. So this was the case for brain tumors. Can this be done with other tumor types? So I'm going to show another patient presentation. This one is obvious for everyone in the room. This is a male, an African-American male, presented to the Geo Clinic with pelvic pain, urinary symptoms. Blood tests show PSA 20.2, and imaging shows an enlarged prostate, pelvic lymph nodes, and iliac bone lesion. So clearly high PSA, this is prostate cancer. It's a little bit young, and actually there is disparity of prostate cancer in African Americans that are recognized. And this is a very important model lacking to understand why the disparity in African Americans for prostate cancer. A lot of work is done on this. I think looking at the translational aspect of these PDOs in prostate cancer will be very important. So we decided to design a study where we include the PDO in the current care of prostate cancer. First, the NCCN guidelines this year for prostate cancer define the treatment based on the stages. So if it is local disease, usually it's surgery or radiation. If it is advanced or metastatic, the case, to remind you, had pelvic lymph nodes, had evidence for bone lesion due to bone pain. So it will be defined as either castration resistant or castration sensitive. Majority of advanced prostate cancer will present as castration resistance, particularly from African-American patients with prostate cancer. So they will be in the class of androgen deprivation therapy, ADT, followed by these different types of chemotherapies. About 20% of advanced prostate cancer patients will develop metastatic disease and die within 3 to 5 years. So while it's not highly lethal as brain cancers, there is significant morbidity with this disease. So work from Memorial Sloan Kettering, the group of Charlie Sawyer and colleagues at MSK, developed in 2014 a system to derive PDOs or organoids from advanced prostate cancer patients. And the slide here is showing the different validation of these PDOs from prostate cancer in terms of the genomics involved in it, the histology, the expression profile. As you might notice, the efficiency was very low. It's about 15%. This is very limiting if you actually want to scale a model and use an assay that can be applied to many patients. You can't apply it in 1 to 6. So you need to improve on the efficiency of organoid formation. And this is what we felt when we started this work. Indeed, when the Sawyer group published their Nature protocol. Later on, they indicated that their system only works from metastatic cells in the circulation, but not the actual biopsy or the original prostatectomy tissue. We decided to focus on the prostatectomy tissue and initially develop a way where we can make correlation between the different sections of this prostatectomy tissue. We reported this work earlier, where we could do a section to develop sequencing based on DNA and RNA expression, section to confirm histological assays, and a section where we can separate the cells. And these cells can then be used for organoid formation. The slide here is showing some of these biomarkers that are essential for diagnosis of advanced prostate cancer, like the presence of the TMPRSS-ERG fusion, which is a key diagnostic marker for about 40% of prostate cancer patients will have the TMPRSS-ERG fusion done by FISH assays, and it's a key diagnostic feature. So we defined first all the biomarkers, the assays that can be done to advance an organoid model, a PDO system from the lab into clinical trials. Next, we designed a clinical trial where we can access the tissue. The goal of the trial was to prevent progression of hormone-naive prostate cancer to castration-resistant prostate cancer. It was designed as a phase 1/2 study, and the key is access to both the normal adjacent tissue as a control, to the tumor, the primary site, and to the metastatic site. All of these were collected as part of this trial, and a partnership between the clinical team and the research and translation team. We developed this PDO system with 3 different stages. The trial included multimodality therapy. So the androgen deprivation therapy is the key standard of care that is used, followed by Taxol in this group of patients. We get these tissues, we develop the PDO and correlate them to the patient responses. We actually did this on 52 patients of advanced prostate cancer. Some of them were reported last year in the phase 1 study. The focus of the PDO assays and what I'm showing you here are 19 patients, all with advanced prostate cancer and some with metastatic disease. We were able to generate these PDOs from all but 2. And the limitation is actually the amount of tissue or the size of the biopsy. I'll show you here a few examples of how this is done. So first, the panel A is showing the system that we developed to make these patient-derived organoids. We get the biopsy tissue within the hour from the OR with the help of the biobanking group. The tissue then undergoes processing and development into PDOs within, in the case of prostate cancer, it takes about 12 to 14 days to derive a single cell to make an organoid. A key feature is that we have a large panel of PDOs from African-American patients. This is actually, to my knowledge, the only source in the country for PDOs derived from African Americans that we can do studies on. The panel in the bottom, panel B, is showing evidence that they are single cell derived. So we took these cells, we labeled them with a lentivirus that expressed GFP, followed the GFP expression for 14 days, and you can see that these are all single cell derived. And the histology of these mimic the original histology of the biopsy of the patient. How can we use this system? We then did first the validation of the genomic sequencing. So we compared the expression signature in panel A using RNA-seq and the genomic profiling to the original biopsy tissue. Then in panel B to D, developed a biomarker assay. So again, we're looking at multiomics. We want to go from genomics to RNA to expression, either protein or IHC or so. So in panel B to C is the proteomic assay. This is a quantitative assay for PI3K signaling, where we developed several nodes within the signaling to show pathway activity. This is confirmed with pathway analysis. And with this score that is shown in panel D, we can distinguish the activity of each pathway based on these proteomic signaling profiles, and now apply it to the design of targeted therapy for these patients. So we test the system with different therapeutics shown here, and indeed, those that have high PI3K signaling respond better to the targeted therapy than those that don't have high PI3K signaling. So it's another step of doing more precision in your types of targeted therapy, linking the profiles of the patient-derived PDOs to the actual responses to therapy in these tissues. And indeed, this reflected PSA scores. So as you all know, prostate cancer is defined by PSA responses, and all the drug responses matched the PSA scores, further validating the system. So this allowed us to actually design it on a quantitative basis where we can define first line of therapy and second and third line of therapy for each of these patients and develop a score where it is given to each of these responses. And now the patients are taking all of these different types of therapies. So now we are matching the PDO responses to the patient responses in the clinic. We can add more assays, like, for example, if the patient is taking abiraterone, which requires cytochrome P450 signaling. So the limitation here for this being a 3D in vitro culture is addressed by looking at CYP assays in these types of culture. So this allows us to make correlation between the responses in the PDOs to the actual responses in the clinic. The first phase of the study is published last year. The remaining phase 2 is ongoing, and I hope to update you on some of these responses in the coming meetings. So what I showed you so far is that we've generated PDOs from a large number of patients, that they have features morphologically that mimic the original tissue. We can combine the sequencing of DNA and RNA and protein assays to design targeted therapy for these. In the last part, I'll show a third example, and this is work that is done here at Anschutz since I joined last summer, so very preliminary, but happy to take your input on the design and what we have done. And it is focused on lung cancer. So one of the things actually that drove me to come here is the really outstanding expertise in the clinic, in the Department of Medicine, particularly Division of Medical Oncology and the Thoracic Oncology program, because of their ranking as probably top in the nation and maybe top in the world. So we have an amazing team, and this is the only way advances and new things can actually be applied. No one works in silo, and it's all about teamwork. So I'm fortunate to team up with a very strong group in the lung cancer field and develop these type of assays focused on the PDOs for lung cancer care, and different than what I showed you previously, which is more correlative, more retrospective. Now we can take this a step further and actually use it to implement therapies. And the key question is, how do you do this? All of this, if you ask anyone, well, it's all research, so what? You have a long way. You have 10 plus years to take any of these and validate them and get an FDA approval. And so I want to argue against this motion, as I hope I will show you in a few slides. So now our case is a young female. She's a never smoker. She presents with the common symptoms of lung cancer, unfortunately. This is happening a lot, and actually there is increasing evidence of lung cancer in never smokers and in never smoker females. We don't know why, but this is something that is increasing in the last 5 years. These are the common symptoms of a patient with lung cancer. They will present with any of these 7 symptoms. And particularly if they are a young non-smoker, it is a sudden diagnosis. It's not something that you kind of expect it's coming. Once the patient is suspected of lung cancer, the diagnosis will be with a CT scan or a whole body MRI, and the imaging will show the site of these lesions. Part of the care will be access to tissue again, and this is really the key for what I'm trying to show you, is always the incorporation of these biopsies into patient care. Sometimes it's controversial. Sometimes many people think it should not be done at the same time, but my opinion, access to tissue, even limited as a needle biopsy or so, would allow you a better, more precise diagnosis and therefore more precise therapy. So the biopsy or the standard of care after getting a biopsy and confirming diagnosis of lung cancer, they're either small cell or non-small cell lung cancer. This is the NCCN guidelines for small cell lung cancer. And as you can see, it's generally a combination of radiotherapy and chemotherapy. The 5-year survival for small cell lung cancer is 5%. 19 of 20 patients will die. So the prognosis is bleak, and as you can see, there aren't many advances in the type of therapies that are given for small cell lung cancer. So if we're able to develop models and assays to better understand small cell lung cancer, this will be a significant advance. The case for non-small cell lung cancer, and this is, by the way, a histological diagnosis, as clearly evident from the name, is a little bit better. Indeed, non-small cell lung cancer is the best example of precision medicine to date. The patients are usually diagnosed with a driver oncogene, and that driver oncogene can be either EGFR, ALK, MET, or those listed there. And there are targeted therapies that are developed for these, currently FDA approved, and the patients undergo these types of therapies. Indeed, with non-small cell lung cancer, immunotherapy now is first line treatment for many of these patients. So they have to meet particular biomarkers, and only about 20% of patients will respond to immunotherapy. So if we focus on the oncogenic driver, non-small cell lung cancer, they are usually treated with targeted tyrosine kinase inhibitors. These are either EGFR inhibitors, ALK inhibitors, or so. These TKIs are used for a number of years. Usually in the second year, many of these patients will develop resistance to TKI and fail to respond to therapy. And they will undergo next lines of therapy, but unfortunately, many of them will develop resistance and don't have any other option. So with the thoracic oncology program here at Anschutz, we designed a new program called the TOP. We call it the Thoracic Oncology Precision Program. And this outlines the workflow and the goals of the TOP. We want to take patients that develop resistance to TKI. We will enroll them in a trial. that has two elements: precision diagnostic, where we could do more in-depth assays on biopsy tissue from these patients, precision therapeutics that incorporate the PDO system to tailor and define the ultimate type of therapy. This is done in collaboration with a number of groups, mainly the group in Stanford, working on whole genome profiling of these tissue, and a number of commercial companies providing cell-free DNA assays. So the goal of the top is really to personalize therapy, to personalize non-small cell lung cancer care. And this is done at the single cell level with whole genome sequencing, with taking organoids from the biopsies of these patients and developing targeted therapy for them. We focus on mechanisms of resistance. As you all know, you can't do everything to start with. So we designed it to do three main targets to identify mechanisms of resistance. First, on-target resistance, and this is focused on by using the whole genome sequencing and exome sequencing on these 6 different targets. In the center part, we then define what are the possible mechanisms of resistance from a non-primary resistance. Let's say the patient was initially an EGFR positive, that they switch to any of the other targets. And the third possible mechanism that we are focused on are related to plasticity or a change of phenotype. And as I showed you, the IF assays, the immune fluorescence, will allow us to actually distinguish the different cell types. So these are the program activities since we started last summer and what we are planning to do. The platform is designed to have access to tissue. So we have to include a biopsy into the IRB-approved protocol. The biopsy is divided into 2 parts. One is for diagnostic and one for PDO. And then we develop signatures from these and match them at the end to develop a bioinformatic AI-focused logarithms for defining responses to therapy using these models. We rely on the use of the cell-free DNA. So if you actually take a biopsy, this is the last time you're seeing that tissue from the patient. The evolution happens in the patient longitudinally. So we think that if you take a sequential blood samples and do a cell-free DNA assay, you could actually monitor progression and responses to therapy during this evolution process. And with the biopsy, we use a system that I brought into the Anschutz campus, working with a company called NanoString. This allows us to do thousands of markers on one slide. And with that, you can do both the transcriptome and the multiple markers at the protein level on a single biopsy. So again, the concept of multiplexing and doing multiple targets on the same biopsy tissue. And then going into the patient-derived organoid assays, if you recall, I mentioned the efficiency was low in making these organoids. So one top goal for our program once we started is to actually improve the efficiency of making these organoids so we can design them to be a clinical assay. So far, and this is very preliminary since we started in the summer, we've done 6 patients. They're all metastatic non-small cell lung cancer patients. We were able to generate PDOs from 5 of these and also do all the different phenotyping, cell typing within these PDOs. And this may be the key slide, the take-home slide for the lung cancer work, is the system that allows us to actually improve the efficiency of the PDO. So instead of looking at markers, we decided to develop a system where we look at driver oncogenes. And in this, we do a multiplication of drivers in 3 different conditions, 1, 2, and 3. So the patients will be grouped into these conditions. We validate the growth assays with IF. I'm showing an example here where the patients have a splice variant P10 mutation that shows susceptibility to PI3K targeted therapy. And indeed, when we do what's called the P10 essentiality assay, you can see highly significant responses in these PDOs. So we take these PDOs and then design tailored therapies using the FDA guideline. If the therapy is already approved, that means the patient can actually access these treatments once this is validated. If the therapy is experimental, it will take a longer way. If the patients are already approved, it is actually possible to repurpose them or do a compassionate care program so patients can actually access this type of therapy. So this particular patient shown in panel C to G was on a third-line ALK inhibitor, a drug called lorlatinib. This is after taking first and second line, they develop resistance now on the best state-of-the-art standard of care for non-small cell lung cancer ALK positive patient. Indeed, unfortunately, the patient also developed resistance to lorlatinib. So we took a biopsy, we developed the PDOs into our system, and then run our logarithm for the expression profiling and identify two compounds that these organoids are responsive to. Fortunately, one of these compounds can be used as a compassionate care. So the patient went on this compassionate care type of study. In the 6 patients that we examined so far, we have identified in at least 2 of them alternative therapy. They can be either taken as compassionate care or enrolled in a clinical trial. And this table outlines the different profiles of these patients and what they can get. So overall, the PDO assay, I hope I convinced you to some extent today that it supports translational and clinical trial correlative studies. It can be used for pharmacological drug screening. Ultimately, with the regulatory approval, we hope to have this as an assay or a companion diagnostic test that you can then use it for antibody drug conjugates, any types of therapies. I have not touched on the immune modulating agents, which can be done also in the system. The assay would allow us to develop SOPs to really improve and personalize the type of therapy on campus. And this is not only for cancer care. I believe this is the direction for all different types of care. You will have an assay derived from the same patient that you can tailor. You can design the personalized type of therapy based on improved multi-omic diagnostic and validated responses in patients' own cells. Finally, I want to thank some of the people who've done the work in my group and all the collaborators on campus and others. Left some time, I hope, for some question. And I was asked to have this for any nomination that you guys want to do for next talks. Thank you.
Sabi, thank you very much for that talk. I really appreciate it. For folks in the audience, we are soliciting nominations for speakers for the next 5 weeks for this coming Grand Round series. So please do take advantage of this. And I'll start with Dr. Badish.
We're beginning to hear about the use of tumor targeting vaccination in like melanoma.
I apologize. I can't hear you well.
All right. Can you hear me now?
Yes.
Starting to hear about tumor targeting vaccination in melanoma and whatnot. It seems like it's the ultimate personalized or targeted therapy and whatnot. Are you able to use your organoids to develop vaccines?
Yeah. This is a great question for the audience on Zoom. The question is about personalized vaccines that shown evidence in melanoma and whether they can be used in the same system. So I would say absolutely. I think, the PDOs are derived from these original biopsies. We can define the immune peptidome in the cells from these tissue. We've done similar assays. We have not yet taken it into the vaccine, but similar work we've done in the organoids derived from mouse models, and we can actually show efficacy of peptides derived from mouse-derived organoids into models of vaccination. So this is a future goal, and I think the combination of immunotherapy and vaccine therapy, particularly even RNA-targeted vaccines, and those are showing a lot of promise after COVID, and there is work from 2 lead companies that developed the COVID vaccine on RNA vaccines derived from these signatures. I think the PDOs have a key role here in showing efficacy in preclinical studies, but also continuous access to tissue and signature. We freeze these. You can come back to them once the patient have resistance. So there is a lot of value in the vaccine field. Thank you.
Oh, sorry about that.
Thank you for the really interesting talk. I had a question about the scalability of these PDOs for routine care, for routine clinical care for all the patients here. It seems to be, would it be cost effective in the long run to be able to do this for every patient? And also, I had a question whether you see a difference between what the response you have in the organoids in the lab versus what actually happens in the patient, the in vitro and the in vivo kind of effect?
Yeah, those are great questions. So the 2 questions are whether we can do or use the PDO assay prospectively to design therapies. And the second question, whether the responses in these lab-defined PDOs mimic those in the patient. So I'll answer the second question first. Responses in the PDOs have been validated to mimic those in the patient in at least 6 different studies, large clinical trials. I will name a Science paper in 2018, including 52 colon cancer patients where they derived organoids. This study was done in Germany. They derived the organoids. They selected the therapy based on the organoids, treated the patient, and showed that the responses match. So at least in colon cancer, this has been validated. In other tumor types, there are less validation in the literature, but overall, when comparing apples to apples, the models that we can use now, the organoids are more superior than any of these other models that can be tested. I think it remains to be finally validated in each tumor type whether the responses would match. And at that time, this will be the ultimate way to design personalized therapy. We're doing these studies now with the prostate cancer work I showed earlier. So we want to be able to show that the responses we already have in these PDO matches what's going on in the clinic. With the lung cancer work, we're trying, and this is to address your second question, can we use them prospectively or use them to design therapies? This is the goal of our lung cancer work. We wanted to design the models, have them scaled first. We can make them in high efficiency. We wanted to improve the diagnostic assays to be able to have molecular signatures that can be used with them with limited amount of tissue. So this is the key for most of the work, whether cancer or not. In the clinic, the biopsy is very small. What do you use it for? You have to use it for clinical care. So by scaling the types of assays, going into more innovative assays, that you can do hundreds and thousands of targets on one slide will address that issue of the limited tissue availability. And then improve the precision of the diagnostics. So we're not just focused on one marker or so, and then validate the responses to therapy of the organoids in vitro, in mouse models, then go to patients. Because we will not be able to get approval for every type of therapy and every test we're doing. Currently, the system, as I mentioned actually in my very first slide, it's focused on developing a drug, a target, it will come a day when we have all of these covered. We have scaled up all the diagnostics. We have multiplexing of biomarkers. And at that time, we'll be able to design tailored therapies for every patient.
I think we're right at 1 o'clock. So Dr. Sabawy, thank you very much.